Hello everybody, welcome to my 2021 update on abbreviated MRI for prostate cancer detection in biopsy naive men. Here are my disclosures. When we talk about biparametric MRI or MRI without contrast, we really have to compare with multiparametric MRI, and multiparametric MRI that's done according to the PIRADS standard. So a multiparametric MRI is a multiplanar T2, dynamic contrast enhancement, and diffusion imaging with p-values less than 1000 being used for ADC map calculation, and an additional ultra-high b-value image that could be extracted or calculated from the lower b-values or acquired de novo. This, of course, takes the most amount of time and is, of course, the most expensive. Biparametric MRI does not compromise on the T2 or the diffusion, but does not use contrast medium. And, of course, the new fast MRI is a uniplanar T2 image, no contrast medium injection, and the diffusion imaging is compromised because there are two b values. The second higher b value can be higher than 1000, so there's a non-constrained ADC map. And of course this takes the least amount of time and is the least expensive. Today we'll be discussing biparametric MRI without contrast medium, comparing it to a multiparametric MRI, which is of course a multiplanar MRI. You'll often see images like this that are shown up obvious PIRADS 4 lesion at the right prostatic apex in this patient who has high-risk prostate cancer. And people will say, well, what's the point of the DC MRI sequence? And I would agree. There is no value in this particular instance of the DC MRI sequence. However, we have to remember that DC MRI in the PIRADS system is reserved for the PIRADS 3 category in the peripheral zone. Now, PIRADS 3 categories in this particular instance is 11%. But remember that some of these patients have already moved into PIRADS 4 in this particular instance, although the proportion is unknown. So it's certainly greater than 10%, possibly 15%, possibly 20%. In other words, 1 in 5 people need contrast enhancement to be able to do the correct PIRADS categorization, which is not unsubstantial. So you see this debate between biparametric MRI and multiparametric MRI, with the people who say that biparametric MRI is ready because of operational improvements. Well, the problem is that the operational improvements are highly dependent on image quality, which will affect diagnostic performance. People will point out to the fact that there are only minor impacts on contrast medium usage on imaging assessments. I've just shown you that it could be up to 1 in 5 patients. People will point to the non-inferiority of the diagnostic performance, but there is a great deal of heterogeneity in the performance, and I will show that to you shortly. And the scientific evidence is insufficient against a variety of clinically significant prostate cancer definitions, and we'll come back to that. Negative scans, of course, can be called on a biparametric MRI, which can help to minimize overdiagnosis. But remember, there are other benefits of multiparametric MRI beyond overdiagnosis that we also need to consider. So the chief advantage of biparametric MRI is operational. In other words, it's about us radiologists. Faster examination time, reduce costs, minimizing contrast medium reactions. And of course, people will point to the non-inferiority of the performance, but this is all about us. But what about the patient and the pathway benefits? We also need to consider that. But before we go on to that, you will find data like this shown to justify the use of biparametric MRI. You'll see that the point estimate is identical, sensitivity and specificities are identical. Yes, but look at the variation of the two. There is less variation in sensitivity for multiparametric MRI compared to biparametric MRI. In fact, the PIRADS committee looked at this recently and looked at all the meta-analyses that were published and said that there were major hazards of using meta-analysis for clinical recommendations in this particular instance. There was a mixing of reference standards. There was a mixing of population. There's mixed definitions of clinically significant cancers. And there were mixed patient and lesion level analysis. And there were very, very few head-to-head comparison studies between biparametric and multiparametric MRI. And when there were comparisons made, the decision to biopsy was based on a multiparametric approach, not on the biparametric approach. In fact, there are no prospective randomized studies comparing biparametric and multiparametric MRI decision-making and how they impact on biopsy, on the test performance and biopsy pathway. And there just isn't strong enough data to recommend biparametric MRI currently. And of course, there are positive effects of dynamic contrast enhancement for prostate cancer diagnosis. It overcomes quality issues including low SNR and technical diffusion imaging failures. It can also explain other causes of a raised PSA. PSA is raised and you don't know whether it's due to malignancy or not at the very beginning. So it highlights look at me lesions, it characterizes lesions, what is that? It diagnoses non-malignant causes of raised PSA, including prostatitis. It triages PIRADS 3 lesions, as we know, and it improves the confidence regarding the presence and the nature of the lesions that are there. In other words, it helps to ensure the delivery of the MRI pathway to all men who come with suspected cancer. And you will see examples like this in your daily practice. Here you can see a PIRADS 3 abnormality, dirty prostate on the T2, no high signal on the high B value image, but low ADC. You can see something here on the ultra high B value. So according to PIRADS version 2, this would be category 3. According to PIRADS version 2.1, this would be category 4. But the contrast enhancement highlights this abnormality. Look at this lesion. And in fact, a targeted biopsy core through here showed a 4+3 cancer. And data like this can be found in the literature, where the value of DC MRI has been shown for PIRADS category 2 lesions, 3 lesions, and 4 lesions. In fact, DCE is an independent predictor for all cancers and for clinically significant cancers in the peripheral zone. And in fact, if you have a PIRADS 3 abnormality that is positive on a DCE sequence, the chance of a cancer is higher than if it's negative, and this is statistically significant. So as we stand today, DCE MRI remains relevant for current prostate cancer definitions. Why? Because if you upgrade from a 3 to a 4 using contrast enhancement, the majority of the lesions are of course insignificant cancers, but there are some significant cancers in there. So current definitions are that larger volume, regardless of grade, is considered by many urologists as being clinically significant. And this may be the case in your center. Any ISUP2 cancer, even microfocal disease, would be considered as clinically significant by many urologists. Of course, if your urologists don't agree with that, they only want the larger ISUP2 lesions and above, then DCE is much less relevant. So it really does depend on your own urologists. So we're really juggling here between the biparametric and multiparametric approaches, looking at radiological and operational benefits. But we do need to consider the pathway impacts of adopting biparametric MRI. So we know that multiparametric MRI will reduce the number of patients undergoing a biopsy. It reduced the prevalence of insignificant disease, but we also know, and it has been shown in randomized studies and in prospective studies, that it improves the diagnosis of clinically significant cancers. Does biparametric MRI also show that? And that's the key thing. Well, if we look at the way that we analyze images using the PIRAD system, we can see that negative MRIs can be defined by T2 and diffusion features alone. Therefore, biopsy avoidance after a negative MRI should be realizable without contrast medium. Of course, you expect this. And in fact, prospective studies show that. So this is the Bidox study, the largest study ever published with biparametric MRI. You can see over 1,000 men, and 30% of men avoided a biopsy after a negative MRI. So there were fewer insignificant cancers. But look at the detection of clinically significant cancers compared to a systematic trust biopsy. You can see that there's only a 2% difference between the yields of systematic biopsies versus biparametric prompted biopsies. Only 2%. It's there, but it is small. And in fact, if you look at 3 prospective studies, each looking at biparametric MRI, you can see that all of the studies enable you to avoid the diagnosis of clinically insignificant cancers because you reduce the total number of biopsies performed. And this applies, of course, equally to multiparametric MRI. After all, you're using the same method of analyzing the data. But if you look at the detection of clinically significant cancers, you'll see that there is only a small increase in the detection of clinically significant cancers using a biparametric approach, but a much greater yield using a multiparametric MRI. And in fact, this was also shown by the Cochrane review. The Cochrane review also showed the same thing, that the detection ratio, the ratio between the detection of clinically significant cancers using a multiparametric approach versus a biparametric approach compared to a systematic biopsy is greater for the multiparametric approach, although this is not statistically significant, but it is detectable. So what we can say is that the biparametric MRI only has a marginal positive effect. The other question is, does it reduce the number of cores per patient? We know that if you apply the multiparametric directed approach, that you can reduce the number of cores per patient. You reduce the number, if you increase the number of indeterminate cases using a biparametric approach, then your number of biopsies within the PIRADS 3 category will, of course, increase. So look at this data from the Netherlands. This is 4 highly expert centers with central image quality control. You can see that the PIRADS 3 proportion increases using the biparametric approach. You can see this is multiparametric, this is biparametric, and this is fast MRI. Remember, fast MRI was a single plane MRI. So even if we ignore this, we can see there's a 20% increase in the number of indeterminate cases using a biparametric approach. So we know now that PIRADS 3 roughly should be between 10 and 15% of your cases. A lot of people have 1 in 5 will be PIRADS 3 cases. The question you have to ask is, can you afford to increase that by 20%? If you are at the bottom end of this scale, 6%, you increase by 20%, that's 1 or 2% more. Really doesn't make a big deal. But if you are here at 20% and you increase your PIRADS 3 category by another 20%, you will be out to 1 in 3 or 1 in 2, 1 in 4. And that's not great. So this is what you have to remember. There are more indeterminate cases. So what does the PIRADS committee say? The PIRADS committee provides no specific recommendations on the preferred use of MRI without contrast medium. They are concerned about technical factors leading to suboptimal image quality of the diffusion imaging and because of low signal-to-noise ratio images. Here is a same patient evaluated on a 1.5 Tesla scanner, a 10-year-old scanner, reported by a general radiologist called a PIRADS 2. The patient has a 3T scanner, 3T scan. This is the diffusion imaging. You can see that this image lacks signal-to-noise ratio. And this is just the problem with an older scanner. The other thing that the PIRADS committee says is that when there are risk factors that indicate the likely presence of clinically significant disease that should not be missed, in other words, somebody with a family history, a prior negative biopsy where you're still suspicious, active surveillance, or when the risk calculator says there's something here, then you should do the multiparametric approach. And of course, if you had a biparametric MRI previously and it was negative, but there's still some suspicion, you should have a multiparametric MRI. Now, of course, not every patient deserves contrast medium. So, for example, if the prevalence is very low, say less than 5%, a man walking off the street doesn't have a raised PSA. Well, a biparametric MRI is probably fine. If you have somebody who is obviously got a large cancer, somebody like this, somebody with high risk, locally advanced cancer, you can feel it, the PSA is high, you know what? There's no point in giving contrast medium enhancement because it hardly ever helps in this instance. But if you're going to use the biparametric approach, you need to have real-time monitoring to decide on the use of gadolinium, and you have to assure the quality of the scan and of the reporter. And really, you should be highly expert if you're going to use biparametric MRI as your default approach. Let me show you some data to show that. So this is how much experience you would need to get a fixed sensitivity depending on whether you're using biparametric or multiparametric MRI. So let's say you were trying to achieve a sensitivity of 90%. If you used a biparametric approach, you would have to have an expertise of 1,000 cases. With a multiparametric approach, you would only need an expertise of 300 cases. So really, biparametric MRI should be used by experts only. And here's the data that shows that. And remember, when you're deciding on the need for biopsy and you're using a biparametric approach, you should use PSA density for making biopsy decisions. So here is the Bidox study that I showed you previously, displayed in a slightly different way. So these are negative cases, these are PIRADS 3 cases, and these are PIRADS 4 and 5 cases using a biparametric MRI approach. You can see that a patient with a raised PSA density of 0.2 and above has high risk negative, and these high risk negative patients, there is a substantial proportion, up to about 30%, who will have clinically significant disease. So these should be biopsied. People who are equivocal on the MRI but have a slightly lower PSA density threshold, you see 0.15 and above, these people should be biopsied. And of course, everybody else should also be biopsied. So any positive case should be biopsied regardless of PSA density. If you adopt this strategy, in fact, the net benefit for the use of MRI is the greatest. So you should biopsy positive biparametric MRIs, i.e. PIRADS 4 and 5, or a PIRADS 3 with a PSA density of greater than 0.15, and that's this blue line here. So what does the PIRADS committee say about the use of contrast medium for prostate cancer diagnosis? They make 5 key statements. They say that unenhanced MRI represents a potential solution for meeting the increased demand for MRI for prostate cancer workup. So it is a potential solution. Optimal image quality and data interpretations are mandatory, based on the premise that there will be a degradation of performance when you start using unenhanced MRI in clinical practice. We know that when you go out of expert centers into the community, there is a degradation of interpretive performance. You need to be ready to institute patient recalls when image quality is poor and in indeterminate cases. Why? To mitigate the risk of decreased MRI reading confidence or inaccurate diagnosis. The PIRADS committee feels that there needs to be higher quality data before they can make evidence-based recommendations about the use of biparametric MRI as the initial diagnostic approach, as I have just talked to you about. And the current analysis indicates the need to have both unenhanced and contrast-enhanced sequences available for prostate cancer diagnosis. So finally, these are my take-home points. We clearly need to think about us as radiologists, thinking about logistics, cost, time savings, capacity, and side effects. But we have to balance this against diagnostic uncertainty that may be brought about by the lack of IB contrast. The biggest problem we have is that there are no prospective multicenter studies on biopsy yields, prompted by a biparametric approach and a multiparametric approach. We need this before we can be confident about saying that the biparametric approach is enough. Thank you very much for listening. I hope you found this update useful. Leave me some comments.